Good evening, friends. मैं डॉक्टर बैनर्जी हूँ from our 34th जर्नल क्लब and ये जो केस मैं लिया हूँ, we have taken this case with some reason. Why? Because this patient is for IVF and when we are doing this IVF and stimulating her, suddenly we found that in between there is a endometrial thickness has gone little bit high. That is more than 16 or 17 millimeter. I have came with this case. She is 36 years old lady, married like 9 years, trying for issues since long, and her AMH is good, 3.24, and we had a regular periods. Last period was on 25th of April 2024, and the other parameters are okay. Uterus is anteverted, myometrium echo appears normal, and endometrium is slightly irregular at the time when we examined that, with left ovary adhered and right is normal with a retention cyst. And we asked her to go for IVF, and we did a hysteroscopy first before going for IVF on 14th May. That is pre-IVF hysteroscopy, and that was cavity was appearing normal and regular. Endometrial cavity was regular, even though there was an increase, slight increase in endometrial thickness when we are examining pre-IVF. So at hysteroscopy, we found that the endometrium is okay. So we started her stimulation, and this stimulation is started from just showing you the thing what we have done. Its stimulation is started from July 8th with HMG, and she was taken in antagonist protocol. The patient has started a period on 7th, and from second day we started the antagonist protocol. On 8th day, there was 6 follicle on left ovary and 4 follicle on right ovary. Suddenly, we found that the endometrium has gone up to 19.1 millimeter. When we found that the endometrium is 19.1 millimeters, so we decided to go for frozen embryo. So basically, what we did in antagonist protocol is that we did day 2 investigation of FSH, LH, E2, and E4. And they were within the normal limit. And when we found that FSH, LH is E2 was less, and it was less than 0.25, 45 picogram per ml, 3.4.5. So within limit, so we started this antagonist protocol, started injecting SMG every day. On day 7, we normally start cetrorelix 0.25. On that day, we found that the follicle on the right side was 4. The left Left ovary shows 6 follicles, and the dominant, the biggest follicle was 26 into 21 mm. The right ovary shows 4 follicles. The largest is 21 into 19 mm. But the endometrium is 19.1 mm. This was little bit worrying. Usually it doesn't happen with this type of, these are not very big number, but so we decided to go for visa and ask her to go for cystoscopy after finishing the IVF protocol. On 17th of April, 17th of July 2024, we did the ovum pickup and total 14 oocytes, total 14 oocytes retrieved. Mature was that is 10 to 12. ICSI done. The single egg is whole and held, and the single injection of sperm, the injection of single sperm is given. And there are 5 blasts. So I will show the blastocyst, what type of blastocyst it was. If the video runs. And this is the blastocyst, and very good quality blastocyst. This is the opioid. This is sonography. Very good quality. So there, hatching also, this is a 5 variety. So 5 blastocysts. Yeah. 22nd July 2024. These are generous and mass and very good quality. So there are 2 5A, 2 4A, 1 3A. Now the problem is, if this lady is having endometrial hyperplasia, we are going for frozen embryo transfer. Why there is hyperplastic endometrium? So we ask her again to go for hysteroscopy. Now we did the hysteroscopy and now see how the hysteroscopy looks. This is the hysteroscopy video, and you can see there are a lot of, it was not present in the idea, but suddenly we found that there are multiple sort of polypoid growth, multiple sort of polypoid growth inside the uterus. This worried us that why it is. So we did biopsies from these polyps. Now the problem is, if this is abnormal and if it is a malignancy, then how can we do embryo transfer? So we did a biopsy and sent this histopathology to the pathologist. We have Dr. Rinku and Dr. Rajesh with us. Dr. Rajesh has studied the slide. Ask him to please come here. Comment on the slide which is seen in the trees, right? Before commenting on the slide, the brief note over the technology of the endometrium, technology of the endometrium, and what hyperplasia means. So you can see that this is the uterus. The endometrium binds to the uterus in the form of the inverted triangle. The layer that is towards the myometrium, that is known as the basalis, and the towards the cavity, that is known as the functionalis. So, with the action of the hypothalamic pituitary and over the ovaries, the estrogen acts over the endometrium functionalis basically, so that the endometrium start proliferating. So, the day of menstruation we count as the one, and from here the estrogen levels starts rising. So, the estrogen levels first starts rising, the proliferation of the endometrium starts. So the basalis layers come towards the towards cavity, that is the functional layer, and the proliferation starts. So the normal histology of the endometrium from day 1 to day 5 is highly proliferated. Lot of mitosis take place, and the glands they start proliferating as well as the stoma. So basically, what you see in the endometrium, there are a number of glands, and they are spaced by the stromal tissue. Stroma is basically supporting tissue, which is spindle shaped, and there are some amount of lymphocytes and neutrophils also in them. And the glands are basically tall columnar. And as we call it, from the day 5 onwards, estrogen levels starts coming down and progesterone level starts decreasing. From day 17 onwards, the progesterone levels rises so that what happens here, the secretion starts. So basically the cells in the lining trees here like this, we have columnar cells, and the vacuolation starts coming in the basal layers. The coming of the vacuolations in the basal nuclei is the evidence that the secretory phase has started and progesterone effect is going on. So, so what we see is that in the cycle, there is initially the rise in estrogen levels, so proliferation starts, and then there is a decline in these levels and the rise of progesterone levels, so that the preparation for the implantation will take place. And if there is no implantation, there is no fertilization, so then again the thing menstruation cycle starts and the endometrium will start. In this case, what we see, we have the whole Sorry. Okay. So we can see here this picture. You can see these are the
So these are the endometrial glands. These are all the endometrial glands. And we say endometrial hyperplasia when more than 3:1 ratio of the gland to stomach, 3 times increase in the glands to the stromal ratio. Then we call it hyperplasia. Initially, we used to call the hyperplasia as super hyperplasia and complex hyperplasia. But now these terms have been obsoleted. Now there are only what is WHO class. There are two terms for the hyperplasia. One is the typical hyperplasia and atypical hyperplasia or endometrial intraepithelial. So, so whenever there is a simple the typical hyperplasia is there is always and always some amount of stoma is there between the glands. Okay, and when it goes towards the epithelium, that means the stromal layer expands. So here you can see the glands. These glands, there is hardly any stroma in between. These are the different glands over here, and they're lined by the tall columnar cells. With the higher overview, these are all glands, and they are all they are separated by the very compressed stroma. Stroma is highly compressed, okay? And they are all lined by the tall columnar cells. But there's some amount of nuclear is also present. Prominent nuclei. And these glands are all back to back. So the stromal component is minimal. Okay, there are some, secretory effect is there. Here. What we call secretory effect. And you see here, prominent over here. So according to the, this is a atypical endometrial hyperplasia, and to know whether it is going towards the malignancy or endometrial hyperplasia, you must do P53 immunohistochemistry so that you can know the proliferative index of this tumor, and accordingly you can do the management. So
what I just want to ask, by looking at this, we are a little bit now concerned about her, whether she is having physical, not because
these are what is endometrium, and so there is a very compact. There is somewhere in between there, some amount of nutrient. So can be a case of endometrial intraepithelial. And to know the extent whether it is progressing towards the carcinoma, we should always
P53, if we want to do, then we have to do another biopsy.
no, there's a block only. There's a block.
P53 will give the idea about the Embryo. The problem is this lady, she has not completed her family. She has come for infertility.
Yes.
That is the biggest dilemma with us. And no, we have already measured the embryo. The problem is, as a clinician now, I have to take a call whether her uterus should be left or not. Because there is a problem of so there are in textbook, I asked Ashita to join with her slide. We have to consider what to be we should do with this type of cases, whether if we don't keep the uterus, then where to put the embryos. But life of the lady is also very important. And it is very difficult for a clinician to disclose this thing to a lady who already gone under IVF, preserved her embryos. And if there is a problem in uterus, life threatening take a call to remove the uterus also. You should go for a surrogate and immediate treatment should be good. But there are methods which Anita will tell what is the clinical management for a clinician, how we can.
To start with the management, first we need to understand what is endometrial hyperplasia. So in simple language, endometrial की treatment अगर ज़्यादा so it is endometrial hyperplasia. So endometrial hyperplasia is often associated with multiple risk factors. So whenever we are assessing a patient for endometrial hyperplasia, a lot of common risk factors. When such risk factors having any abnormality in ultrasound and endometrium have to be taken into consideration, they might get endometrial hyperplasia in future of endometrial hyperplasia, endometrial carcinoma. So what during the menstrual cycle, endometrium goes through different phases. And there is so pathologist at the person with ultrasound, what we need to do to diagnose something which nobody has not seen a lot of people taking into consideration. So, if there are 10 millimeters, 70 millimeters is not a the split is 17 by 2 millimeters can be normal. In a normal, 24 months. Whereas, what not for menopause, that they are not done. For ACOG, it says that 4 millimeters above it is extra. Then you have to it has to undergo evaluation. If the clinical guidelines are recommended, 3 millimeters for patients on HRT and 5 millimeters for patients who are taking HRT. But what about women who are menstruating regularly? So in these cases, what there should be a strong degree of suspicion. And important thing is on which most mental. Suppose this is a second or third day. In fertility practice, you usually get patients who come to us on second day, third day, fourth. That finds can do it. Even if child was it's a why because after having period, it should be fed off. It's not supposed to be 12 millimeters. 13 millimeters. So the more important question here is that these patients who are not menopausal, who are not perimenopausal, who are younger, there the diagnosis becomes difficult because there is no clear cut guideline like we have. If it is like that, then we have to say this is hyperplasia. So here, what we have to see is clinical history. We have to evaluate for risk factors. Then we have to see the texture of the endometrium, whether it is regular, whether there is some polypoidal growth. So there the role of hysteroscopy comes in place. What happens many a times that we see such patients, there are patients irregular bleeding, they have a polypoidal growth or anything. We think that the young patient, she's 30 years old, right? Taking some medication. Or we simply do a blind dilation during that procedure. So over there, what we have taken that even if we've done that procedure, we're not sending the sample for any time that. But we have not done it. We have not seen the texture properly. So that is why we are missing. So that is why in any case where we are suspecting an endometrial growth or hyperplasia, hysteroscopy remains the investigation of choice which has to be performed. Earlier, they used to say that we can do this, we can do that, but now hysteroscopy is definitely the investigation of. Then the risk factors, there are a lot of risk factors, obesity being the most important because with in obese women, the rate of estrogen production becomes more because of the adipose. Chronic anovulation is an important risk factor in patients having PCOS, hyperprolactinemia, all these things. Then early menarche, late menopause, any estrogen secreting tumors, glandular cell tumor most commonly, Patients on tamoxifen. Tamoxifen is a drug which is given for treatment of estrogen receptor positive breast cancer. So in such patients, many a times it has a side effect that it has positive estrogenic effect on the endometrium. So that causes hyperplasia. So such patients always have to be under strict evaluation and monitoring. Every 3 months they have to go on 3 to 6 months they have to undergo an ultrasound. And if at all there is any signs of hyperplasia, they have to undergo a biopsy. If we talk about the Lynch syndrome, it is caused by mutation of DNA mismatch repair system. So these genes MSH1, MSH2, MSH1, MSH6, and BMS2. These are DNA whenever there is a DNA repair system in our body. So whenever this repair of damaged cells or damaged DNA is not taking place, it will give rise to cells which should have been stopped before growing, which had a malignant potential. Whenever this system fails, so these cells keep on growing, and ultimately causing the hyperplasia and progressing into a cancer. So Lynch syndrome and another important is HNPCC syndrome, which is uh, related to colorectal cancer and multiple polyps in the colon. So this is also another genetic. And the important factor about genetic disorders is whenever we encounter a young patient, so genetic disorders start to be because this patient might be at the risk of other cancers also. It is many a times an associated cancer in these conditions. So whenever we see a younger patient, we should definitely evaluate the genetic disorders which are associated. Now,
Just, just, there are certain mutations which are actually they are also found very much associated development of disease. 10 and these are like genes which actually the receptors for the estrogen. So the mutation of this gene will cause the down regulation of the receptors. So there is no check over the so there is excessive effect of the estrogen. So
that is so whenever there is so the main pathophysiology behind this is that
Point is that what Dr. Rajesh has told that whenever we as a clinician, whenever we feel that age is less,
we should evaluate for a genetic problem because there might be associated cancers as well. Many a times ovarian cancer, breast cancer, these are and colorectal cancer. These are associated with endometrial.
and here almost nearly 40% chances of
so for these cases, we should ask them for clinical examination to know the status of the other part of the genetic.
So earlier, what classification we used to study was it was divided into 4 categories: simple without atypia, simple with atypia, complex without atypia, and complex with atypia. So the recent WHO classification has only said whether there is atypia or not. The simple and complex terms have been removed. So what they are trying to focus that if there is atypia, it is the patient is at risk of cancer 30 to 40 of these patients ultimately will their disease will turn into a cancerous state. So now for
Just want to know whether even though there is the extent membrane is intact, can you say something about that? Is within the innovative, which is
we are studying we are only studying the endometrium. That is specimen.
okay.
So then only we can know the information. That is definitive. Otherwise, the endometrium only and then we go to other one.
so So this is the classification. But for our even clinical health, what we have divided is that we are taking the atypical into consideration as a separate entity, and for simple and complex hyperplasia, for ease in management, we are still, because the whole classification is still being followed, so we are still taking the simple and complex into some consideration. So whenever there is a hormonal imbalance, that is whenever there is excess of estrogen, there is remodeling of endometrial tissue, there is inflammation, and this progresses finally and leads to progression. There is inflammatory cytokines, leukocyte infiltration, some non-specific proteases, and these finally lead to endometrial. So the diagnostic test, as I said, the first suspicion is always with the transvaginal ultrasound. Transvaginal ultrasound gives a very good idea about the condition of the endometrium. And even we can, if we can encounter a patient with even endometrial carcinoma, transvaginal ultrasound definitely can give an idea about the mass, its location. So earlier MRI used to be called the investigation of choice, but with a good transvaginal ultrasound, definitely you can help you in at least diagnosing the case. Then endometrial biopsy we have to take, but ideally a microscopic biopsy is advised in such cases because we have to see the cavity as a whole. And then many a times what happens when we are taking a blind biopsy, we have not seen the cavity as a whole. Many a times there is a growth in the anterior wall, in the posterior wall, in this wall, this wall. So we have taken a blind biopsy. We don't know from which wall we have taken, whether we have received all the four quadrants properly or not. Many times in one quadrant you can find a simple hyperplasia, in another quadrant a complex one, and in another quadrant we can find atypical hyperplasia. So ideally a four quadrant biopsy has to be taken guided by microscope, especially in a postmenopausal woman. Blind biopsies are nowadays not considered that one. Hysteroscopy is considered good. Now, endometrial hyperplasia. So, so as I said, that for the ease, because of these two classifications, for the ease of treatment and deciding the protocol, if it all we find a very simple hyperplasia, there is no thing, we can go for low dose progesterone therapy. Then, if there is complex hyperplasia, but there is no atypical, then we have two options. If the patient is post-menopausal, then we can try giving low dose progesterone. If there is no response, go for a hysterectomy directly. If there is positive response, she can undergo 6 months later another biopsy. If it is normal, then you can continue the management if she wants to save the uterus. But if she is premenopausal, if she has not conceived, then definitely low dose progesterone is the first choice. If there is no response, we are going to increase the dose because we don't want to straight directly go ahead with the hysterectomy, especially this patient who wants to conceive. If there is positive, then regular biopsy. Then, if there is atypical hyperplasia and postmenopausal woman, hysterectomy is the treatment of choice. If she is premenopausal and she wants to retain her uterus, then we have to start with a high dose progesterone. Over here, there is no good for a low dose progesterone. If there is no response, we go for hysterectomy. If there is positive response, then we can go for continue this therapy and regular annual biopsy. Now, according to the Green Top guidelines, what they have recommended, so treating hyperplasia without anemia. If we don't have anemia, so LNG, IUS, that is Mirena, and oral progesterone are equally effective in both these cases. Mirena is considered the first line of management because it provides a good local progesterone level. When we are giving oral steroids, we always have a difference in the dose taken, the amount of blood reaching the blood, the first pass metabolism, everything. So considering that, Mirena is considered the first line treatment, and whenever it is compared, it has a better disease regression and more favorable profile with the patient and lesser side. So, if you want to give oral progesterone, medroxyprogesterone 10 to 20 mg or non-progesterone 10 to 15 mg per day continuously. This has to be kept in mind. It is not a oral contraceptive. It is not something that you want the patient to menstruate regularly. We have to give it on a daily basis. Cyclical progesterones have no role in the treatment of this. We repeat the biopsy in 6 months to see whether there is regression of the disease or not. And for postmenopausal women requiring surgery, the surgery, if at all she requires surgery, if she is not responding to treatment, then what surgery we should do? We should do total hysterectomy with bilateral salpingo-hysterectomy. That we need to remember because this disease is caused by a hormone which is produced in the ovary. If we're going to leave the ovary behind, there is no point. We have to remove the ovaries and then treating hyperplasia with aphasia. So whether the woman is postmenopausal, she wants to retain the fertility, she doesn't want to go for hysterectomy. First time, ideally, hysterectomy. If there is aphasia, you can go for hysterectomy. This is what green drop guideline. But if she does not want to go for hysterectomy, then she has to be counseled. First of all, most importantly, what risk she has. Because she needs to know what might happen to her. Sometimes we go for the treatment and cannot explain the risk. Then patient might come back and say that we were not experienced. You have to explain them that they have to undergo strict follow-up. Follow this line of management. Only then we can go ahead with on this one. Then pre-treatment investigation has to be done to rule out invasive cancer or if there is any existing ovarian cancer. So whenever we starting treatment, we have to rule out if there is any cancer. We can even do a post-mortem biopsy and see if any part of the uterus we have an invasive cancer. And histology, imaging, and tumor marker results have to be obtained before starting therapy. First line treatment definitely intrauterine device. Second line is oral progesterone. In 3 to 6 months, follow-up has to be done. Another treatment which we can give is injectable progesterone, that is medroxyprogesterone acetate injection. So whenever there is a chance that patient might not follow up with the oral therapy regularly, not willing for a Mirena discussion, so we can go for DMD injection. It is for patients who might not be able to continue oral therapy continuously, who feel are not reliable enough that they will take continuous therapy. And because the only side effect DMDA, the difference between oral and injectable is that in injectable you cannot take it back. Once you've given it, it is going to stay in the body for 3 months. So if at all you want to, during the treatment, in 3 months, if you see a progression and you want to go for hysterectomy, then it is of no use giving that injection. But with oral therapy, you can stop it at any time if there is a side effect or if the patient wants to go for hysterectomy. And in asymptomatic women with the uterus and evidence of this regression, then at least 2 negative biopsies should be taken. Then uske baad we have to do 6 to 12 months of follow-up. So if this patient wants to conceive, what we have to do ideally is give 6 months of therapy, then we do a repeat hysteroscopic guided biopsy. If we see disease regression, then we go for an embryo transfer. She goes through her pregnancy, childbirth, and later on, after 6 weeks of childbirth, either she can go for again continuing this progesterone therapy, or she can go for or of the injection. So that is the plan of management. But during this time when we are trying to regress the disease in this female, definitely we have to every month or every 3 months we have to follow up or follow up. We have to see whether the patient is compliant towards the medication or not. And till the time we don't get a negative biopsy and we don't see signs of disease regression, we should not go ahead with the embryo transfer or not go ahead with the pregnancy, whatever the patient is desiring.
Dr. Rajesh, this is one of the very difficult thing to decide regarding the patient's fertility and stage and looking at the quality of endometrium by histopathology and we are getting this. Yeah. Suppose I give a progesterone therapy and then I do ultrasound and I found that what I feel that with ultrasound, if there is a less amount of endometrial thing, I think that is a good sign. But I just wanted to know from you, if I do a repeat biopsy, how long I should give progesterone and repeat biopsy if she is responding, then what will be the histopathological feature of her in recovery?
This is a response to the therapy. And definitely she will be having the typical normal formalization.
So stroma will improve.
More and more
It is clear should see that.
yes. And we get more and more of these supporting trauma.
Okay, between the glands.
The number of glands will use the number, more of this removal will appear.
Is there what you see in it? If you see the nucleus or the attachment of the
There are mutations that are there, but those mutations so there is some change. Not change like of variables. So glands will look more not same, but their contour is different. There are some small glands, some big glands. There are some capillary regulations, like position. All those things can be found. But once the response to the treatment is there, the glands begin the normal contour. And the proper spacing of the glands.
can I know about the immunostaining what you are telling? Because I have to give this idea to my patient also. What should I tell my patient that what he should do? And what I should get the idea about whether he will be responding or not? Because as a clinician, I am a doctor. Now I have to tell the truth whether we should keep her uterus or not. So
With P53, suppose P comes negative, that will be not very much. It will definitely respond to this one. But then, though it is a hyperplasia, but it is not progressing towards this.
okay.
But the prolonged control that the estrogen level, actually not. So with the touch and response therapy,
He might. But the problem is I have another thing in my mind that suppose he goes regression and he has got the normal glandular appearance and normal stoma. Now I have to prepare her endometrium with estrogen. And if he is conceiving, then again it is a hyperestrogen.
Pregnancy is more, there's more progesterone.
More with
In pregnancy, the disease progression is not really. So the pregnancy definitely, and we read in this factor also, that pregnancy is a negative factor for the disease.
because it produces more progesterone.
And
so should it be under
yes, even with patients having endometrial carcinoma in situ or endometrial cancer stage 1, that is only localized, the fertility spelling procedures have been tried. They are using Mirena, they are using high dose. So dose will increase definitely. Then you can go up to 100 to 100 mg per day.
So my question is, Ashita, if we are giving a DMDA, then we should apply biologist IUD also along with that. There will be more local.
We can do that. It is the first line of treatment. Since we've already given a DMPA, the progesterone is going to stay in the body. And then there's first pass metabolism also because it is directly going to the blood. DMPA, because in foreign countries, DMPA is not that much in use. That is the problem. We don't have that many studies.
Studies.
In our Indian setup, we are because of the cost effectiveness, the compliance, because we can rely that we are giving some nutrition is going to stay in the body for 3 months. That matters because many times we have patients, they just stop taking treatment. They forget medicine.
Have you ever read any literature regarding the serum progesterone level to be maintained for the therapy? Is there any study that this much amount of progesterone should be in the body, then only it will be more effective? Being a hydrocortisone tablet or EMBA.
Not specifically that, and then continue the doctor.
Actually, at such level,
We have to maintain higher progesterone than estrogen. We have to balance the estrogen diet. The only thing is we increase the dose. As we read, first we start with low dose, and it is not responding, we increase the dose. But with age,
Now, for
we don't
responding-
want that, so we will go with higher dose.
For responding, what is the protocol should be used? Have you read that?
For we can go for an ultrasound, we can see whether the progressing, whether it is progressing. Every 6 months, we have to do the feedback.
So if the repeat biopsy, if he says that it is, but now it is this and glands are better, then we can go for.
So we can directly go.
So this is a very, thank you, Dr. Rajesh, for coming here. We are very, very honored that we are feeling very happy that it is an interactive meeting, and I requested him and he accepted the request and came here to discuss with us because this is a multi-faculty and we have to take a help of a good pathologist because he is the person who gives the idea whether what we should go ahead. So
Diagnostic and deciding.
Give the correct reporting of the information. Then only we can know about what is status of the
The
information.
entire management depends on the stage, that is histopathologist.
What biopsy and what
So I think we did a correct way of approach that we identified this Endometrial hyperplasia at the time of stimulation. And we did histoscoping because I convinced her to get another histoscopy. And then we found that polypoid growth multiple and we took biopsy from that. The biopsy has been proven for with ATPia and now we have given the patient as an injectable DMPA and I am thinking about putting levonorgestrel IOD also to get the local as much as possible progesterone exposure to the surface of the embryo. I think that will be the better thing. Thank you very much for joining us and thank you very much Dr. Rajesh for the beautiful meeting. Thank you.